right, knock, knock. I'm washing my hands. Hello, Mr. Hoffman. How are you today?
Doing well, thank you.
My name is Nancy. I'm going to be doing an assessment of your heart and the vessels in your neck today. So I'm going to start out by asking 2 questions. Do you have any history of heart disease?
I do not.
Have you ever had a heart attack or a procedure where they put in a stent?
No, I haven't.
Heart failure?
None.
Okay.
No.
Do you ever experience any chest pain?
I do not.
Okay, good.
Now let's palpate the carotid artery. Now, whenever you're doing this, you want to, again, compare sides like how you were whenever you're listening. But what you're going to do is you're going to palpate lightly. And what you want to use is your index finger and your middle finger. Do not use your thumb. And avoid putting too much pressure on the carotid sinus, which is up in this area, because this has sensitive baroreceptors, and especially in the older patients, your elderly patients, you could cause vagal stimulation, which will slow the heart rate down. So do not do that. It's generally good to palpate in the lower half of the neck to avoid that carotid sinus area. And what you want to do is you want to locate the trachea and the sternocleidoid mastoid muscle, and in that middle of that groove is where you will find that carotid artery. And what you're looking for, what you're actually feeling for, is the amplitude and the contour. You want it to feel smooth and rapid, have a rapid upstroke and a slower downstroke, and you want to grade it. And a normal grading is 2+. If it's really hard and bounding, it would be 3 or 4, and if you can barely feel it, it's diminished. We are going to auscultate the carotid artery, and what we're listening for are bruits, and that's what I talked about at the beginning of the video. And this is where you have a turbulence of blood flow, and it will sound like a blowing or swishing sound, and this is indicative of atherosclerotic narrowing. And what you want to do is you want to use the bell of your stethoscope, and we're going to listen in 3 different places to get a really good assessment. We're going to listen at the angle of the jaw, so find the jaw, and we're going to go right below it, so we're going to go in there. And then we're going to go mid-cervical area, which your cervical area is your neck, and we're just going to go in the middle of it, so we're going to go about right there. And then we're going to go at the base of the neck. And the key whenever you're doing this is you want to press lightly with the bell of your stethoscope. And whenever you're doing that, you're just pressing lightly, because you don't want to create a false bruit or compromise circulation by narrowing the arteries. And what you want to do whenever you do this, you want to have the patient take a breath and have them exhale and hold it for a second while you're listening, so you're not hearing breath sounds and it won't mess with the sounds that you're hearing. So we're going to listen real fast. Take a breath for me and exhale. Okay, take a breath for me and exhale again. Okay, again. Okay, and that sounded great. And then you're just going to compare sides and repeat on the other side.
I'm measuring jugular venous pressure, or JVP.
Begin with your patient at 45 degrees. This is especially important, as you'll soon see. Ask them to look away from you, up to their left, and try to make out a pulsation in their internal jugular vein, which is located between the sternal and clavicular heads of the sternocleidomastoid muscle. However, the pulsation is difficult to see and may not even be visible in a healthy patient. The important thing is to differentiate it from the carotid pulse. Unlike the carotid pulse, the JVP is non-palpable and consists of 2 beats per cardiac cycle rather than 1. If you're uncertain, you can apply gentle pressure to the abdomen to see if the JVP rises as a result of the abdominal jugular reflex. If the JVP is visible, its height is measured from the sternal angle, perpendicular to the ground, as demonstrated here. The JVP gives an indication as to the pressure in the venous system. You can think of it as the column of blood waiting to fill the right atrium from above. The higher the column, the higher the pressure.
I'm going to move down to the chest. I'm looking at the precordium. The precordium is the part of the chest that overlies the heart. And I'm looking to see if I see any pulsations or any movement there, which I only see normal respiratory movement. And then I'm going to palpate the point of maximal impulse, which is at the mid-clavicular line. and the fifth intercostal space. So it's going to be, if you put your fingers right here on the ribs, feel in between the ribs, and then you'll feel that pulse.
First, place your warmed hand at the apex. Feel for the apical impulse. If palpable, it should lie at the left midclavicular line. The impulse should last no longer than systole and be no wider than 1 centimeter, and it should feel gentle with no heaves or lifts. Next, move to the left sternal border, feeling for a displaced or widened impulse or other abnormalities. Then palpate at the base of the heart to detect any problems. Fine rushing vibrations, called thrills, may be felt at this site.
In reality, if a person has an enlarged heart, there are many much more sophisticated testing that are done to see a heart enlargement, but we can assess the relative areas of enlargement. So the heart is in this area, and so what we're going to find out is the areas around here will be nice and resonant where it's lung space and air space, but when I hit the heart, it's going to change to dull. So we can basically start and do any rib space, do second intercostal space, and start mid-anterior axillary line. And there's my spot. It changes from resonant to dull. I can go to the next inner space down. There it is. So I could actually make dots the whole way along and mark it, and I would actually have the outline of the lateral border of the heart. And the one that's the most important is the fifth intercostal space, because the fifth intercostal space is where the mitral valve is, which is the left ventricle. And if any of the chambers of the heart will enlarge, it will be the left ventricle. So for this one, which is the most important, you want to start at the mid-clavicular line, mid-axillary line. And you can hear the sound change right there. I've hit the left ventricle, the apex of the left ventricle. You can also make sure that the heart hasn't shifted to the right-hand side. By coming along and making sure the whole right-hand side is resonant. On a female, really the only rib space you can do is the fifth rib space coming across. And again, on a female, you would ask her to take her right hand, cup her breast up, her arm would be out of the way, and you can just slide like right along here, along the contour of the pec muscle.
On to auscultating the heart. So you start by finding the second intercostal space. So you can either count down from the clavicle, okay, there's space 1 and there's space 2, or you can find the angle of Louis. This is the part of the sternum that protrudes a little bit, and right across from there is the second intercostal space. So I'm going to start by listening with the diaphragm. So make sure that you have your stethoscope set up the right way. Start in the aortic area. Just have the person breathe normal. And I'm listening for the S1 and the S2, the lub-dub. And I'm listening for any clicks or extra sounds or murmurs. Okay, that's the aortic. Right across from that, second intercostal space to the left of the sternum is the pulmonic area. And then as we move down, I'm going to listen to the left at the fifth just right next to the sternal border. And then finally at the mid-clavicular line, the fifth intercostal space, the mitral area. So I heard S1, S2, the lub-dub. I did not hear any clicks or extra heart sounds, and I did not hear any murmurs. Now I'm going to do the same thing with the bell of the stethoscope. So second intercostal space to the right of the sternum, the aortic area. Then Then to the left of the sternum in the second intercostal space, the pulmonic area. Okay, right next to the sternum, the fifth intercostal space, the tricuspid area. And then finally the midclavicular line, fifth intercostal space, the mitral area. I heard S1, S2. I did not hear any extra heart sounds, and I did not hear any murmurs.